Thank you so much to the Academy and to Eve for the invitation to be here. I'm thrilled as always to be back in Canada, especially Vancouver. I did my internship here for physiotherapy, and it's wonderful to be back. Patrick, I do want to say it's raining really hard on the East Coast right now. And it's dry here. But anyway, it's also wonderful to be able to come back and talk to this group, but also to think back to all the wonderful collaboration I've had with some of your fantastic pain researchers from Canada when I worked in program at NIH, and also on some of these strategies that I'm going to talk to you about today. I was fortunate to be invited to the CIHR Pain Research Forum a couple of years back. So there's been a lot of interaction back and forth between our leadership at the NIH and also with colleagues in Canada. So I've been asked today to talk to you about some of the programs that we've done, how things have changed as far as pain and pain care goes. And I think you'll see that my story is very similar to what Maria has just told you about, on a different scale and with somewhat different challenges, but the burdens, the overall challenges, including even especially for us, I think, the political instability and how that all affects some of the programs that we're working hard to move forward. So let me go back to the very beginning. The story starts with advocacy, and I can't tell you how important this has been to moving our programs forward. Before the Patient Protection and Affordable Care Act came out in 2010, better known as Obamacare, the Patient Care Coalition in the United States had been working so hard to get a pain care bill through Congress to just set up some really essential baseline needs to improve the quality of pain care. And finally, in this bill, the Affordable Care Act, there was a pain care bill embedded in that. And two of the big items that pain care bill called for was to set up an IOM, which was the Institute of Medicine, now our Academy of Medicine, a conference on pain, to look at pain at the public health level, what the problems were for public health, what the burden was at the individual level, to look at the kind of care we have or don't have at the time, to look at barriers to improving care, and to establish a plan to move forward to improve pain research, education on pain and pain care, and care itself. The other important thing that Affordable Care Act did was to create an interagency pain research coordinating committee. This is a trans-agency committee that has a lot of power because it's congressionally mandated. And so their mandate was originally targeted very much to only research efforts. I say only in a way that it's not because of lack of importance, but the fact that this became a much broader effort on their part because of their willingness to help out beyond the scope of their skills and expertise. So the first thing that we see from the IOM report is it became a very influential book. I call this the Little Purple Book. It made a big difference in increasing public awareness amongst government officials that could help us out about what the needs and burdens and challenges were for improving pain care across the country. So with that book, they told us that 100 million Americans report pain. This was adults only, didn't include children or people who were incarcerated, so the numbers were probably much bigger than that. Slightly after that book came out, the Purple Book, we had a number of studies that came out on population-level research. 25 million people live in daily chronic pain in the United States. At least 8 million of those have pain that interferes with their lives, and I think Maria outlined really nicely how it can impact your daily life. Social activities, family commitments, being able to go to work. The cost of pain, and this is in 2011, they estimated to be about $635 billion as far as healthcare costs and lost productivity, a big, big number. They knew that access to quality care was limited across the entire population, but also was much more devastating to certain vulnerable populations. They were asked to look at the state of pain care in the United States. These are just a couple of quick examples of how things had gone bad in the U.S. So we have some numbers on who lives with pain. These are adult statistics. 28% of people over 20 have joint pain. Almost the same number have low back pain. Slightly lower number have arthritis or neck pain. Huge number of people have headaches. Where do we care for that pain? Not in the right places. So 20 years ago, we had specialty pain care clinics across the United States. Now we have a very limited number. So most of our care happens at the primary care physician's office, where education and time is very limited. A lot of pain care happens in the emergency room. People who don't have appropriate health care or haven't had success with their primary care provider end up in the ER. This is not a good place to have chronic pain treated. There are some hospital inpatient centers who can be a little bit more effective, but again, we're not doing our job right. Part of the problem is the healthcare system has changed. We moved from a comprehensive, more integrated system that we had decades ago into a probably more costly system that treated on a per modality basis. So we turned to medications. They're an inexpensive, a quicker, easier way to begin to treat pain, but certainly not an effective way. So some of the current stats show us that 22% of adults with chronic pain use non-prescription analgesics. 27 of them use prescription analgesics for long periods of time. So what are the problems? What are the challenges and the barriers to better care? So the Little Purple Book told us that we have problems with access. That's partly because it's a big country. We have rural communities. We have people who are uninsured, and they cannot get any kind of care, in some instances, never mind quality care. The reimbursement system that we have for integrated care as far as pain goes is virtually non-existent. So for some chronic disorders, there is a payment structure in place where you will pay for sort of a bundled package. For pain, that's not the situation. We pay on an intervention basis. It's not always evidence-based as to whether the intervention is effective or the cost-benefit risks, the risk and benefits are not appropriately taken into consideration when those policies are set up. So we have a public payer system and we have a lot of private payer systems. They are not similarly set up as far as they compensate for pain care. Education, I think Maria hit the nail on the head with this one. That study that came out that showed our medical students get so much less time than our veterinary students was really, really telling. So this is a huge gap in providing quality pain care. Awareness at the public health level, again, Maria talked a bit about this, that patients don't have the knowledge they need to go to their physician and ask the right questions. What are the risks of this particular intervention, this treatment that you're prescribing for me? Is it the best for me? So they don't know what to ask, and many of their providers, especially primary care providers, don't have the right answers anyway. The evidence base for pain and pain care is actually fairly strong, but getting that out into the clinic and into the model-based systems of care has been problematic. So what we know, we don't always use appropriately. And so we move from there, from the Purple Book, into an action plan. So in the Affordable Care Act, it said, make an action plan to make things better. So identify the public health problem, it's pretty much in the book, and then establish action plans to reduce the barriers, improve pain research, education, and care. So that action plan is what the National Pain Strategy Report became. So in response to this IOM report, the Assistant Secretary for Health came to our Interagency Pain Research Coordinating Committee and said, we know you are established to manage and strategically plan for pain research, but we have this bigger issue that needs to be managed. Can you set up a report to develop a national action plans for a national pain strategy? So they took it on, and according to the recommendations of the IOM report, we went and developed a set of working groups. Again, you'll see the topics here are similar to those that Maria pointed out as areas of high need in order to improve patient appropriate and quality patient care. So we set up 6 working groups, one on prevention and care, one on services and payment. Again, our reimbursement system is totally muddled as far as integrated healthcare goes. Professional training for both the primary care and the specialty care providers, public awareness, and population research, just really to see if any policies that get put into place are really starting to make changes in how pain is cared for. So the report was put together in a way that the stakeholders we brought into this process, which were probably about 80 people from across a number of different disciplines. We included patients, we included clinicians, we included researchers, we included people from different government agencies that support pain research and pain care, and also people that are affiliated with accreditation in the medical schools, and had conversations on a bi-weekly basis for almost 2 years. And the outcome of those conversations was a set of objectives. So each one of these working groups put together 2 or 3 primary objectives. Within those objectives, they were asked to identify very specific, concrete goals and aims where we could make a difference over the next 1 to 5 years. So we tried with this national pain strategy, let's take some steps now, reassess in 5 years, and see where we need to go on a bigger scale from there. A challenge, but I'll give you a little bit of a progress update and show you how things have changed as far as meeting of those objectives. But before I do that, I want to mention that you didn't see in that bubble chart the research strategy. So I mentioned we have the Interagency Pain Research Coordinating Committee. Once the National Pain Strategy Report was done, they turned back to the research plan. So we did our National Pain Strategy Plan and our Federal Research Strategy Plan a little bit in reverse order of what you have been doing here in Canada. So to do the federal pain research strategy, we set up a similar set of work groups, topically a little bit different, had conversations again over the course of a year, and came out with a set of priority research recommendations that were handed back to the government agencies so that those recommendations could help guide their planning strategies and their funding strategies for the research that they support. And we set the working groups up a little bit differently in that we could look at the continuum of pain from a patient perspective. So we looked at prevention, we looked at acute pain, the transition from acute to chronic pain, and how disparities affects pain and pain care. And again, we pulled in stakeholders from across all the arenas that I mentioned before. We felt it was really important that we had broad buy-in from the very beginning so that we could engage these same groups and same individuals once the reports and the strategies were released. So we then went back and handed over all this information to the Health and Human Services, the Secretary, and we set up an implementation plan to move forward with the National Pain Strategy. And again, we go back to, sort of these different levels of sort of pulling in government officials from the agencies who were really relevant to moving pain care forward, and make sure that our original stakeholders would come back and help work here. So we set up a principals council a steering committee, and work groups. The Principals Council was meant to be leads from all the federal agencies that support pain research and pain care. And here comes in, our political transition year. If you remember, the pain strategy came out in 2016. That's an election year for the president in the U.S. And so we had our principals, who would be leaders of, for example, the FDA or for the CDC. They kind of typically disappear in a transition year, but there's usually some settling after that. And what we found in these last couple of years is that our principals kept leaving. And so we didn't really have the Principals Council to oversee the National Pain Strategy implementation. And I bring this up to show you what one of our challenges has been to implementation, and also one of the things that has slowed down the implementation a little bit. The work groups are meeting, we're moving forward with trying to achieve some of the objectives of the National Pain Strategy. Again, these are really discrete things, and so some of these have been moving forward sort of through the working groups themselves successfully, and so we're hopeful in that regard. What we are really struggling with is resources, and this is a blank slide for a reason. We were never, the National Pain Strategy, I'm going to fill it in a little bit, but this is, was never given dedicated resources from day one. And this was a struggle where the folks who helped us put it together said, well, we're going to do all this work, and then what's going to happen to it? So we were hopeful that with the public awareness of the burden of chronic pain in the country and the needs of the people, that resources would come. You build it and somebody pays for it, is what we were thinking. And so before we had dedicated resources, our advocates kicked in, helped us with a patient perspective for needs and achieving our objectives. Professional organizations actually came through with some dedicated money for some of the research objectives. The American Pain Society put in some nice paid for nice grants to work at self-management for pain and research in that area. The federal partners used a lot of their programs to move some of the objectives forward, especially in the population research area and in the reimbursement area. And one of the things we were able to do was to pull together a huge national survey on what the private payers and the public payers actually cover for some chronic pain conditions, which is helpful. We know where we are, so we know where we need to go. We've been working on some educational tools and resources for providers, and we've had a large systematic review done, what's out there in the literature to show what modalities are actually effective for which pain conditions. And so we're actually, we're getting help also from the care providers themselves. We have a group at UC Irvine that's working very hard to pull together a multidisciplinary set of core competencies for pain education across the disciplines, which has been really helpful. So kind of in the middle of all this, we've been trying to get forward the message to the government. We know we have an opioid crisis. And if we cannot improve how we manage pain care, we cannot deal with the origins and the needs to deal with the opioid crisis. And so, we woke up one morning and all of a sudden every day in the news there's a problem noted of someone, the population statistics are going up, more people are dying. Initially, this statistic sort of helped push the need for better pain management awareness forward across the nation. Many people who became addicted early on, up until 2010, had used prescription opioids before their addiction kicked in. This is a heat map of what we looked like in 1999 as a country in 2016 for overdose rates. So the blue are lower and the red are higher. It's a pretty telling statistic. And one of the other consequences as pain care changes kind of came into vogue, if you will, and began to get more support, was that there were unintended consequences on pain care created by some of our early moves in the government to move forward to address the opioid crisis. The CDC guidelines, I think, were taken more as policy rather than guidelines, and so many people had difficulty getting access to the prescription meds that they needed when those guidelines came out. One unexpected consequence of the opioid crisis was the HHS created a strategy for the opioid crisis and included the need to give more research, support, and the need to advance the practice of pain management. So our message that pain needs to be included as part of the government effort to address the opioid crisis was coming through, I think, loud and clear. They put together, again, this is a congressional bill, a pain management task force that's meeting now and will report out in another month about what the practice guidelines are and what the gaps in those guidelines are and how they need to be improved across the nation for improving pain care. So I think this is going to be a really, really important resource. The other thing that came out of the awareness of the opioid crisis is money, and lots of it, for pain research. This is something we've been waiting for years and years. So in 2018, we were given $500 million to spend over the course of 18 and 19 towards pain research and opioid and addiction research. It's made a huge difference for us to be able to build infrastructure into the pain research needs. And that money was doubled in 2019. This is a very, very high-level overview of the projects and infrastructure that we are now working to build into the pain research community. And we think that this is really going to accelerate the discovery of new drugs, the development of new drugs, the testing of treatments, whether they're pharmacological or non-pharmacological, and will make, hopefully, a huge difference. I have like 30 seconds. So here's where we are. We've really benefited from advocacy. We've benefited from partnerships now. We're working with industry to get information on their failed and successful drug development programs. One of the things that's really important is we are now, as NIH, working with the Centers for Medicare and Medicaid Services to provide the research base for them to change their policies about how they reimburse for pain care. This is a big, big step forward for us. We know more about population level data. We're hoping we can change practice guidelines. And we think that our research agenda is really going to make some differences because of its expansion over the course of the next several years. Here's what we've learned. There's a lot of value added from the alignment of the priorities that we found in our research strategy and the need for policy changes. We really needed to ensure that the opioid crisis and pain management came together and were both supported. Stakeholders from the very beginning were so important to implementation if they had helped us out with the plan. The challenges are resources. We're getting there, but this has been a struggle. We're finally feeling like we're moving forward that. And the breadth of the problem. The breadth of the problem from the point of view, as Eve pointed out, from the complexity of pain, and the breadth of the problem from the healthcare system being able to manage the pain. I think Patrick reminded me this morning that some Americans said he was a little surprised at how complicated healthcare is. So we're moving forward, and we're actually really excited. This is a time for us when it feels like, as a country, we're making a difference in how we improve pain care. So thank you very much again for the invitation.